Hi everybody, my name is Dr. Joshua Cohen. I'm a GYN oncologist here at UCLA Medical Center. Thank you very much for logging in today, or thank you for watching this at home on YouTube if you're watching at a later time or date. Today we're going to be talking about a topic that is near and dear to my heart. I am an OB/GYN by trade, and then I did special training in cancer, women's cancer, and became a gynecologic oncologist. Today the focus of our discussion will be what patients can do during their OB/GYN visit, whether it's an annual exam or if you're coming in for some particular reason, to optimize and make sure they get the most out of that visit to reduce their risk of certain cancers. So with that, we're going to talk about gynecologic cancers and what should you ask during your OB/GYN visit. And if you do have any questions, please feel free to post them on Twitter with the hashtag UCLAMDChat, or you can comment on Facebook. We are monitoring the Facebook live stream currently. September is Gynecologic Cancer Awareness Month, and in particular for us, this is a very important time to bring attention to cancers, particularly women's cancers that don't often get the same press that other cancers do in the U.S. population. And what we'll talk about today are those specific cancers and what we can do to reduce the risk of those cancers while working with your OB/GYNs. Sadly, in the U.S., 98,000 women will be diagnosed with a gynecologic cancer this year, and unfortunately 30,000 women will die secondary to a gynecologic cancer. I think one of the most important things that we can do today is discuss anatomy, and I firmly believe every patient should have a very good understanding of what is normal for them. So with that in mind, a few things I'd like to point out. So this is a picture of the female genital tract, and here we have the uterus. The uterus is where babies grow, so when moms are pregnant, that's where babies mature over time. That's also where the lining of the uterus builds, and when someone has a period once a month, the lining sheds from the uterine cavity. The cervix is part of the uterus. This is the cervix here, so this is the top part of the uterus, called the uterine fundus. This is the part of the uterus called the cervix. The analogy I use is that they're all part of the same state. So if you can imagine the state of California, the top part of the uterus is Northern California, and the southern part of the state is the cervix, also known as Southern California. So while they're different, very different geographic regions, they're all part of the same state. Sadly, different cancers can arise from those different places. So a cancer that arises in the uterine fundus or Northern California can be very different than a cancer that arises in Southern California, also known as the cervix, with this analogy. The other parts of the anatomy that are important to know are the ovaries and tubes. So once a month, a woman will ovulate from an ovary, one or the other, right or left. That follicle will then travel down the fallopian tube and into the uterus. If there's sperm there, that becomes a baby, and that's where babies develop. Cancers can also arise from the ovary or the fallopian tube. There are fallopian tube cancers and ovarian cancers. Another part of the female genital tract that's important to note is the vagina. So the vagina is the part that extends from the cervix down, and there are cancers that can arise from that space. The outside of the vagina is called the vulva, spelled V-U-L-V-A, and we'll talk about vulvar cancers during this talk as well. So the different cancers that I'd want you to be familiar with are ovarian cancer, endometrial cancer, also known as uterine cancer, cervical cancer, vaginal cancer, vulvar cancer, and another important cancer, although it's not directly related to this portion of the female genital tract, is breast cancer. Our OB/GYN doctors are very experienced in doing breast exams and being able to order breast imaging, and one of the things that you can do as a patient during your visit is to have a discussion about the different types of breast imaging and breast health to prevent breast cancer, and we'll talk about that more as well. With Gynecologic Cancer Awareness Month, this is a picture of the different cancers again. I'd like to bring your attention to the Foundation for Women's Cancer. The Foundation for Women's Cancer is a wonderful organization that's associated with the Society of Gynecologic Oncology. That is an organization that I'm a part of as a gynecologic oncologist, and there are a number of wonderful pieces of information on the website for the Foundation for Women's Cancer. Looking at this diagram, again, we have cancer that can arise from the uterus, cancer that can arise from the ovary or the fallopian tube, cancer that can arise from the cervix. So again, imagine one state, Northern and Southern California, uterus, the top part, and the cervix, the lower part. And then vaginal cancer and vulvar cancer. Vulvar cancer being the part of the genital tract that is outside of the vagina. I get some very common questions, and I find that there are some very common misconceptions about your visits to the OBGYN, and I'd like to address some of those now to hopefully alleviate any of these misconceptions. One question I often see, sadly, from patients is, my doctor did a pap smear. I don't understand how I have a cancer along the uterus or the ovaries or tubes. And the misconception here is that if your OBGYN or your primary care doctor does a pap smear, that does not test for cancer along the uterus or the ovaries or the tubes or even the vulva. It doesn't test for breast cancer. The only thing it's checking for really is cancer from the cervix. Again, the cervix is the mouth of the uterus, and that's where moms dilate to have babies. Another misconception is that if someone does a pelvic exam, your primary care doctor or your OBGYN, that they would have found a mass or a cancer if it were there. Unfortunately, pelvic exams are helpful, but they're not a wonderful screening method, meaning there's a reasonable chance that you could have something in your pelvis and your OBGYN or your primary care doctor may not feel it on exam unless there's something more noticeable, like a big mass or nodularity or swelling or pain. One of the most common things that we now test for are inherited mutations in our DNA that we've inherited from our mom and our dad that put us at a higher risk for cancer. Unfortunately, I meet many women who have different types of gynecologic cancers, and again, one of the first things they say is, Dr. Cohen, I don't know how this happened. I have no family history of cancer. Why did this happen to me? And while we do know that there are many genes that can cause these types of cancers, unfortunately, the vast majority of these cancers are sporadic, meaning that they're not inherited from your mom or your dad. And so although you may not have a history of any of these cancers in your family, I still want you to be aware of them and have a good line of communication with your OBGYN, your family practice doctor, your primary care doctor. The last misconception that I do want to mention is that, and this is another common question I get, is, Dr. Cohen, should we do a pelvic ultrasound at each visit when we see our OBGYN? And the answer is no. There's no data that says doing a pelvic ultrasound at every visit with your OBGYN is going to be helpful in finding a cancer earlier or finding a cancer at all. If you do have a symptom or concerning a finding on your exam, let's say that the doctor feels a mass, or if you have pelvic pain or you're having abnormal bleeding, those are all reasons to do a pelvic ultrasound. Or if you have a very strong family history of cancer and you've been diagnosed with a mutation in your blood. But just to do an ultrasound because you show up for an appointment may just create more anxiety and likely will not result in any fruitful outcome for you. And so I recommend having a discussion with your OBGYN, but not necessarily anticipating that you should have a pelvic ultrasound every visit that you attend at that office. Ovarian cancer. So sadly, in ovarian cancer, 23,000 women will be diagnosed with ovarian cancer this year. 14,000 women will die from ovarian cancer this year. The reason that this is a major problem for us is that we tend to find these cancers later, meaning that they already tend to be an advanced stage cancer because by the time they present with symptoms, the cancer is spread in the abdominal cavity. These symptoms include bloating, feeling full quickly, abdominal pain, urinary changes, meaning changes to how you pee or poop. That's constipation, diarrhea, or bladder changes, peeing more frequently. There's also abdominal pain, vaginal discharge, and vaginal bleeding. If you're having these symptoms, it's important to communicate this to your OBGYN. What are some risk factors for ovarian cancer? Smoking, a strong family history of these cancers, something called polycystic ovarian syndrome, something called endometriosis, and then lastly, infertility. Now, these last three bullet points are very common, and this is not meant to be scary. This is just meant to say that if we look at a population-based level of patients who develop ovarian cancer, it appears that these risk factors certainly are associated with it. That does not mean that you will develop ovarian cancer in any of these settings. A common question I'll also get is, do infertility drugs lead to ovarian cancer? Every 6 months we have a new trial that comes out that says that may or may not be the case, and at this point I've not seen any data that says without a doubt that it is associated, and so I am not in any way recommending my patients avoid infertility treatments. In fact, I would encourage them to undergo infertility treatments if it makes sense for their reproductive wishes. If you look at ovarian cancer, although it's a rare cancer, it's the #1 gynecologic killer of our patients. So this is a list of cancers in the US for women. Although ovarian cancer is very rare, about 1 in 70 women, it's the 5th highest cancer killer among women, which tells us that we need to do better, and we need to do a better job both treating and preventing this type of cancer. 1.5% of the US population will develop ovarian cancer, so it's rare, 1 in 70. And when I say ovarian cancer, I also mean fallopian tube cancer. If you remember that the diagram here, the fallopian tube hangs over the ovary, and in fact we think many cancers that we used to call ovarian cancer are likely fallopian tube cancer. There's also something called the peritoneum. The peritoneum is a saran wrap that coats our body, the inside lining of our body. We can't remove the peritoneum, it's always going to be there, but cancers can arise similarly from the ovary and fallopian tube that appear to be a peritoneal cancer. 20% of these cancers are inherited, meaning that the DNA from your mom and your dad may increase your risk of this cancer. And currently we don't have very good screening tests. In fact, there are no screening tests that have been proven to find this cancer earlier. This is a diagram that shows that the vast majority of these cancers, over 60%, are found at a later stage, distant spread of disease. But if we can find these cancers earlier, a localized or early stage, there's a 92% 5-year overall survival. So if we can identify these cancers either through exams with your OBGYN or being vigilant with your symptoms and going to see your OBGYN, we have a much better chance of curing you and preventing this cancer from coming back. What can we do to prevent the risk of ovarian cancer? Oral contraceptive pills are known to reduce the risk of ovarian cancer. Breastfeeding. Women who've had babies seem to be at a lower risk of ovarian cancer. A tubal ligation, or something called a bilateral salpingectomy, removing the fallopian tubes after childbearing. It seems that this may have benefit in reducing the risk of ovarian cancer. And when I say ovarian cancer, I mean fallopian tube and primary peritoneal cancer as well. And then risk-reducing surgery for patients who have a known mutation, meaning that if there's a strong family history and we test your DNA and you have a specific mutation in your DNA, the most common being Brca, and if you have that mutation, we remove the ovaries and tubes at a certain age, we can reduce your risk of developing these cancers. So what should you discuss with your OBGYN? 1, be vigilant. If you're having symptoms, tell your OBGYN and advocate for yourself. New pelvic pain, abnormal bleeding, discharge, decreased appetite. 1 to 2 days of this that goes away, I'm not worried. But if these are persistent symptoms over weeks or months, that's something that's really worrisome. Also, know your family history and ask your OBGYN, should I undergo genetic testing? Who should get tested in my family if there is a role for it? What can be done to reduce my risk? So when you're in the office, say, Dr. So-and-so, should I be on birth control pills? What else can I do to help prevent these types of cancers? And then lastly, if there are any abnormalities on your pelvic exam, discuss with your OBGYN what the next step is. Should you get a pelvic ultrasound? Should you do any blood tests? And have a good line of communication with them to know what the next step is in your care plan. Cervical cancer. So if you remember, we talked about the top part of the uterus and the bottom part of the uterus, northern and southern California. Cervical cancer is the part, again, where moms dilate and babies are ultimately delivered from. In the US, about 13,000 women will be diagnosed with cervical cancer this year. Although it's becoming less common in the US because of good screening techniques, it's something that we still need to be educated about, and you need to advocate for when you're seeing your OBGYN and follow up for routine screening. So what does cervical cancer present with? The most common symptoms include irregular vaginal bleeding, pain with sexual activity, pelvic pain, abnormal vaginal discharge, bleeding after sex, and then changes to how you pee and poop. All of those things can indicate a potential issue with the cervix or a tumor along the cervix itself. If we can find cervical cancer at an earlier stage, then we have a very high 5-year overall survival, above 85% or higher. But if we find it at a later stage, that survival drops down to about 7%. So again, very important to get to your OBGYN or your primary care doctor and to undergo cervical cancer screening. So what is cervical cancer? The most common forms of cervical cancer are caused by human papilloma virus, HPV. In fact, 80% of our population has been exposed to some form of HPV. There are hundreds of strains of this virus. It's usually transmitted through genital contact. But we do have ways to treat or prevent HPV, and the best way to do that is with the HPV vaccine. So if you're at home, if you're a parent, or if you're a young person, I would encourage you ask your OB/GYN about the HPV vaccine, because we know it can prevent cervical cancer. And the age range is approximately 9 to 26 for women and ages 9 to 21 for men, the optimal age range being 11 to 12. Early detection is possible with routine pap smears, and so I do encourage you to talk to your OB/GYN about pap smears and or HPV tests. Sadly, there are some cervical cancers that may not be identified with pap smears, or they may develop between pap smear screenings, and that's again a reason to be vigilant if you're having bleeding between bleeding with sex or bleeding between periods or other symptoms. So what are risk factors? If you have HPV, there are certain strains that put you at higher risk for cervical cancer. If your sexual debut is at a young age and you have more partners, if you're HIV positive or immunosuppressed and you're not able to fight off infections like HPV, that puts you at a higher risk. If you smoke cigarettes, that puts you at a high risk for cervical cancer. And for our patients who've been exposed to DES, diethylbutyrol, it's a chemical that was used in the late 60s and 70s. It's rarer now, but there are women who were exposed to this when they were in their mom's bellies. Those women are higher risk for this type of cancer. What can you do to prevent this? HPV vaccines, I really recommend it. I highly encourage it. Try not to smoke, appropriately timed pap smears, and then discussing symptoms with your doctor, i.e. concerning symptoms like irregular bleeding or bleeding with sex. And so again, to summarize this, if you're having irregular or bleeding or new symptoms, discuss this with your OB/GYN. Ask about the HPV vaccine, whether you're a candidate for it. Ask how frequently you should be getting pap smears and HPV tests, and that varies based on your age and your prior history. And also, make sure you know your own medical history. If you're immunocompromised or you have HIV, then your screening tests will be more frequent than someone who's not immunocompromised, meaning someone who has a functional immune system. If you have any abnormalities on your GYN exam, what is the next step in treatment? And you want to ensure that you get your pap smear result. I see many patients who have said, I saw an OB/GYN 5 years ago and I never got the pap smear result, so I assumed it was negative. Don't assume it was negative. Get the result, have it in your records, be an advocate for yourself. What is uterine cancer? Uterine cancer, again, is the top part of the uterus. That's the most common form of GYN cancer that we see. About 63,000 women will develop uterine cancer in the US this year. What are some symptoms of uterine cancer? Abnormal uterine bleeding, postmenopausal bleeding, pelvic pain, abdominal bloating, changes to how you pee or poop. And then if the uterus is getting bigger and you've already gone through menopause, that's not normal. And that's something that you should mention to your OB/GYN and seek care. And abnormal discharge is something that you should mention to your OB/GYN. What are some risk factors for uterine cancer? There's increasing age. If you're on hormone replacement therapy, you should not just be on estrogen alone. If you have a uterus, you need to protect the lining of the uterus with something called progesterone. If you had your period at a young age, if you never had a baby, if you had late menopause, meaning you were menstruating after the age of 55, if you're obese or you have diabetes, if you have an inherited familial condition called Lynch syndrome, if you've been on tamoxifen for breast cancer, or you have something called polycystic ovarian syndrome, all of these may increase your risk of uterine cancer. Again, it does not mean you're going to develop it, but it may increase your risk. What can you do for protection against this? If you have an inherited mutation like Lynch syndrome, then there are risk-reducing surgeries like a hysterectomy. If you're on birth control pills to regulate your periods, that can be helpful. If you're physically active and you live a healthy lifestyle and you're not obese, that can be helpful. And then again, if you're using estrogen in the postmenopausal setting, I highly encourage you to use a progesterone to protect the lining of the uterus. The symptoms are the same symptoms as we've talked about with ovarian cancer, so please do mention those to your OB/GYN. Your OB/GYN should talk to you about what are different causes of abnormal bleeding if you are experiencing it. You should discuss whether you should have a pelvic ultrasound. That's very common if you're having symptoms or abnormal bleeding. You should also discuss if you need an endometrial biopsy. That's an in-office procedure where they sample the lining of the uterus to see if there are cancer cells. It takes about 2 minutes, and they use a flexible plastic straw to do this, basically. If you're postmenopausal, you should be very aware of the hormone replacement regimen you're on. And then you should also be aware of your family history, because again, there are conditions that increase your risk of cancer from the uterus based on your familial history. And know when you should have a hysterectomy or if you should have a hysterectomy by having a dialogue with your OB/GYN. What is vulvar cancer? So just a real quick reminder here about the anatomy. The vulva is the outside of the vagina. So where the labia are, that's part of the vulva. And you can develop cancers along the vulva. And so the vulva, again, is something that you should be aware of. Know what's normal for you. Your anus, where you have bowel movements, your rectum is below this. Your clitoris is just above the outside of the vagina, and it's surrounded by the vulva. This cancer is rare. Only about 7,000 women in the U.S. will be diagnosed with vulvar cancer, but when it is diagnosed, it can be hard to treat if it's late stage. And so again, know what's normal for you and advocate for yourself. What are some symptoms of vulvar cancer? Vulvar itching, vulvar burning. If you feel a mass along the outside of your vagina, that's new. If you have abnormal bleeding, and that bleeding is coming from the outside part of the vagina. Or if you have an irregular lesion, if you have a mole or something that's growing or changing, you should mention that to your OBGYN or your primary care doctor, and they should examine you. So what should you discuss with your OBGYN to reduce your risk of vulvar cancer? Mention any of these new symptoms, vulvar itching or burning or new lesions. You should also, again, consider the HPV vaccine if you're in the age range, and that's because many of these cancers are driven by HPV as well. Do not just accept a topical cream. Oftentimes, I'll see a patient with vulvar cancer, and for the 6 months prior, she may have been applying a topical steroid or estrogen that her primary care doctor or OB/GYN had said, use this, but they had never done a biopsy. If you're being treated for a lesion or a skin condition or something on the outside of the vulva, and the same actually for the vagina, a biopsy should be done to document what it is. We want to know what we're treating, not necessarily put a topical cream on and assume it'll go away. And so advocate for yourself in that setting. And then know what's normal for your anatomy. Ask your OB/GYN if you can have a mirror, and they can show you what they see and what you should be looking out for. So vaginal cancer is another rare cancer. It's the inside part of the vagina that basically is attached to the cervix. And cancers can arise from the vagina. So again, the cervix is here, the vulva is outside, the vagina is the inside part. And so these are similar symptoms from the prior that we discussed with uterine cancer, but there's discharge, there's abnormal bleeding, there's bleeding with sex, there's new pressure or pain in the vagina. Those are all things that you should be aware of. And what should you discuss with your OB/GYN? If you're having any abnormal discharge that's new, if you have a prior history of cervical cancer or cervical precancers, you may be at risk for vaginal cancer. If you've been exposed to DES, just like with cervical cancer, there may be a higher risk of vaginal cancer. And again, if you're having any new bleeding, we need to understand where the bleeding is coming from. Don't assume it's just coming from the uterus or the bladder. Your OB/GYN and your primary care doctor need to help figure out where that bleeding is coming from to ensure there's no cancer. And then again, do not just accept a topical cream. There should be a biopsy. If someone sees a lesion or you feel a lesion or a mass, they should biopsy it and confirm and know what it is. And if the uterus and cervix have been removed, there still may be a role for pap smears of the vagina if you had a prior history of abnormal pap smears, because you can develop vaginal cancers in a similar fashion to cervical cancer. And again, know what's normal for you with your anatomy. We're going to end with talking about breast cancer. Breast cancer, although it's not part of the genital tract that we've just discussed, it's a major part of women's health and an important aspect of your OB/GYN visit. Breast cancer is by far the most common cancer that women develop that's specific to women. Almost 300,000 women will develop breast cancer in 2018, and sadly 41,000 women will die from breast cancer. There are different stages of breast cancer, and there are symptoms that you should be aware of. So new size or shape of the breast, overlying skin changes, inverted nipples or changes to how your nipples look. If those changes are new, that's something that you should take note of and mention to your OB/GYN. If you have new redness or inflammation along the breast that's never been there before, if you feel a lump or a bump or a mass, or if you're having nipple discharge, those are all things that you should mention to your primary care doctor or your OB/GYN. Again, know what's normal for you, and that's the most important thing. If it's there and it's been there for 20 years, it's likely not worrisome. But if it's been there for a month and it's getting worse, that's something that you need to get a hold of a primary care doctor or your OB/GYN, and they need to evaluate. So what are risk factors? Family history, including BRCA. BRCA is the gene I mentioned with ovarian cancer. It's the most common mutation associated with ovarian cancer, BRCA1 and 2, but it's also associated with breast cancer. Obesity is a risk factor, excessive alcohol use, and then late age of first pregnancy. What can you do to prevent breast cancer? Breastfeeding, living a healthy lifestyle with physical activity, pregnancy. There are certain medications that your doctor can prescribe that can reduce your risk of breast cancer, something called tamoxifen or raloxifene. And so you can discuss this with your primary OB/GYN or your internal medicine doctor. If you have a very high risk of these cancers in your family or personal increased risk, you may benefit from these medications. And then if you have a BRCA mutation or other risk factors that increase your risk of breast cancer, you may be a candidate for a risk-reducing bilateral mastectomy, which is removal of the breast tissue. So what should you discuss with your OBGYN? Discuss a term called breast self-awareness. Again, know what's normal for you, live a healthy lifestyle, know your family history, update your family history with your OBGYN every year, and try to do things to reduce your risk. All of that encompasses something called breast self-awareness. You should ask your OBGYN if you need genetic testing. If you have a family history, your mom, your aunt, your father's mom, all of these may put you at higher risk for cancer. Ask your OBGYN, should I get genetic testing? Should my mom get genetic testing? Should my dad's sister get genetic testing? You should discuss when a breast exam should take place, very appropriate to do at your OBGYN visit. You should discuss the different type of breast imaging. There are various types of breast imaging to do, and it's not as straightforward as it used to be. Ask your OBGYN and advocate for yourself. Should I get a breast ultrasound? Should I get a 3D mammogram? Should I get a standard mammogram? And then review any concerning findings or symptoms with your OBGYN. Again, advocate for yourself at that visit. So what can we do as we summarize and come to a close here? What can we do to get the most out of our visits and optimize our lifestyle for risk or cancer prevention? Again, eat healthy, exercise, live a healthy life. That's really the best thing that I can offer as far as prevention. Within that, though, you can undergo routine healthcare checkups with your OBGYN and your primary care doctor. I would say everything in moderation. Eating some sweets or desserts, that's okay. I mean, you don't have to deprive yourself of the things you like. You just have to do everything in moderation to overall achieve that healthy lifestyle. Listen to your body. I highly recommend the HPV vaccination if you're a candidate for it. And then if you have a concern or there's a high suspicion that you may have a gynecologic cancer, ask to be seen by a gynecologic oncologist, someone like me. Or if there's concern for breast cancer, ask to be seen by a breast surgeon. We are specialists. We can help guide you down this treatment path. At UCLA, we're very fortunate to have a multidisciplinary tumor board, which includes a number of cancer specialists such as myself, where we focus on gynecologic cancers, and there's a similar tumor board for breast cancer, where we have many experts, surgeons like myself, radiation oncologists, medical oncologists, and 15 to 20 people are talking about you at any given time to develop the best individualized treatment plan based on your history. We also at UCLA are fortunate to have the Sims-Mann Center, which is the UCLA Center for Integrative Oncology. And beyond the standard cancer treatments, we offer a number of alternative and supportive measures through our Sims-Mann Center. So lastly, how do we maximize our visit? I would recommend having a list of questions. It's always nerve-wracking when you walk in and you're not sure exactly what to do. But if you have those questions, you'll get them all answered by your OBGYN. Advocate for yourself. Update your OBGYN with family member history and your own personal history. Visits can be packed with information and they can be sometimes overwhelming. Bring a friend or ask your OBGYN for more information you can read about later once you leave the office. And then if it's unclear what tests are being ordered or why they're being ordered, ask your OBGYN to explain them. You deserve that and they will do that for you, or if they're too busy at that moment, they'll call you later and go over that with you. I'm again a member of the Division of Gynecologic Oncology at UCLA. My name's Dr. Josh Cohen. We have 4 locations, Westwood, Santa Monica, Westlake, and West Hills. Again, we're happy to help if there's concern for cancer or if you're at higher risk for cancer. We have a wonderful general OBGYN department that can serve as a very good resource for you as well. I want to thank you very much for tuning in today, and we're going to take some questions now. Okay. So the first question, can you still have ovarian cancer if we remove the ovaries? That's a very good question. The first statement I would say there is make sure you understand whether the ovaries were removed or the ovaries in the fallopian tubes. If you remember the diagram we showed, the fallopian tubes sit right on top of the ovaries. We think many cancers now come from the fallopian tubes. And so it's not uncommon that a patient may say, well, my doctor removed my ovaries years ago, and maybe they left the fallopian tubes in. And so you are still at risk for cancers from either one of those structures, the fallopian tubes or the ovaries. Again, there's also this structure called the peritoneum, the saran wrap that coats our organs. And we treat that cancer, primary peritoneal cancer, similar to ovarian and fallopian tube cancer. So I tell patients if we remove the ovaries and tubes, we reduce your risk of that cancer essentially down to 0, but there's still this risk of primary peritoneal cancer depending on your genetic makeup and history. Another question is what genetic testing should be ordered and who should order it? Genetic testing is something that's very powerful, and I would recommend that if you're OB/GYN and you decide that you would like to undergo genetic testing, I would see a genetic counselor. We're fortunate in Los Angeles to have significant access to genetic counselors, but insurance companies will also offer teleconferencing or video conferencing, and you can also do phone call discussions. And so a genetic counselor who's certified should talk to you by phone or in person or by video and decide what genetic test should be ordered and discuss with you what those results could involve. Then the last question we're going to take today, does chemotherapy still remain the frontline treatment for ovarian cancer, and what are the existing side effects? Every day we're developing new technologies and new treatments for ovarian cancer. Usually, today's the stated treatment for stage 3 cancer, which is the most common presentation for ovarian cancer, is a combination of surgery and chemotherapy. We've gotten much better at the types of chemotherapy and managing the complications, and so not everyone gets the same chemotherapy, but we now have the ability to titrate and adjust those chemotherapies, and we're developing targeted treatments that we can then use after chemotherapy as maintenance drugs or in the setting of a recurrent cancer that are less toxic, like oral pills. Immunotherapy is a new topic. It's a new foray for us with ovarian cancer. We're still figuring out if immunotherapy will have a role. It likely will, and it should, but we're not sure yet where it will be, and that's why we're doing clinical trials at UCLA and other major cancer centers to help figure that out. I want to thank you all very much for tuning in today, and I wish you all the best.